Hello. Today we are going to see about the fetal circulation. This is Dr. Sankarnarayanan, Senior Resident, Department of Anesthesiology, SLIMS Pujay. So, the definition of the fetal circulation is circulation of blood from placenta to and through the fetus and back to the placenta. So here, O2 is uptake occurs in the placenta. Okay, the preferential streaming, delivery of highly oxygenated blood to the metabolically active tissue, that is, brain and heart, and of less oxygenated blood to the placenta. Shunt exists in the venous system, heart, and arterial system. Parallel circulation, this is occurs in various organs receiving portion of their blood supply from either ventricles. So, current knowledge of fetal anatomy and physiology owes a great depth to pioneering work of Groff and colleagues in fetal and neonatal sheep. They have analyzed the fetal circulation from a sheep. So, anatomy per se, what we are going to see is like the placenta. It's an organ of prenatal respiration. So it's going to respire for the baby. It is large and it has very low resistance circuit, so that blood flows very easily through that. The lungs is almost completely excluded from the fetal circulation. There exist a special shunts such as ductus venosus, common novel, ductus arteriosus. These shunts allow the most highly oxygenated blood to perfuse the heart and the brain. There are two umbilical arteries originate from internal iliac artery, and these deliver fetal blood to the placenta. There is only one umbilical vein which carries the oxygenated blood from the placenta to the fetus. Next, we are going to see the diagram. So, the main left umbilical vein carries the highly oxygenated blood, that is PO2, around 32 millimeters of mercury with rich nutrient blood. Much of this blood is diverted into ductus venosus, which connects the left umbilical vein to the IVC in the liver. So, the main left umbilical vein is shunted to the IVC via ductus venosus. This occurs in the liver. Sphincter mechanism in the liver. So the mechanism this regulates the flow of the remaining blood from umbilical vein into IVC through hepatic veins. This physiological sphincter exists and prevents overloading of heart when the venous flow in the left umbilical vein is high. That is, during uterine contraction, this physiological sphincter prevents overloading of the fetal heart. Ductus venosus. So, this is a slender shunt connecting the intra-abdominal umbilical vein to the IVC, mainly like left umbilical vein to the IVC. 30 to 50% of umbilical blood is shunted through the ductus venosus. So this is intra-aortic liver. So this connects the umbilical vein and the IVC, which joins into the heart. Okay. The umbilical, the ductus venosus blood has highest oxygenation because it is directly having the blood which comes from the placenta. The highest kinetic energy in the IVC. So the blood which is entering into the IVC from umbilical vein via ductus venosus has the very highest kinetic energy. So predominantly presses open the foramen valve to enter the left atrium. So it travels to the left side and it opens the foramen valve and it enters into the left atrium. This is called preferential streaming. Ductus venosus, which obliterates within 1 to 3 weeks of birth in term infants, and it takes long time in premature births, persistent pulmonary hypertension, various forms of cardiac malformation. In contrast to the ductus arteriosus, where increased oxygen tension triggers the closure, there are no triggers for ductus venosus, although prostaglandin E1 may keep it open, thromboxans may close it. So, the preferential pattern of left venous return to right ventricle and left ventricle. More highly saturated blood from the umbilical vein passes via the ductus venosus and the left hepatic vein to the left atrium, and from the left atrium it reaches the right ventricle via left ventricle. Less saturated blood from the lower body via the inferior vena cava from the main and right portal vein via right hepatic vein from coronary sinus and from FVC enters the right atrium and then it enters into the right ventricle. So left system, left hepatic venous system which carries the oxygenated blood. See here, the blood from placenta reaches umbilical vein via the ductus venosus. Along with this, left hepatic vein drains into this, which enters into the left atrium, then it enters into the left ventricle. But here, the blood from the lower part of the body enters into the IVC. Along with that, main portal vein, right portal vein enters into this, and uh, along with the SVC, this gets drained into right atrium and enters into the right ventricle. So, right side it has more of deoxygenated blood, left side it has more of oxygenated blood. Next, we are going to see what is foramen ovale. As you know, the foramen ovale is formed by the overlapping edge of septum secundum against the ruptured upper part of septum primum. This is septum secundum, septum primum. So there is a overlap of septum secundum over the ruptured part of septum primum. So this creates a opening that is called foramen ovale. This flap acts as a valve. So for preferential blood flow from right atrium to the left atrium. So the inferior venous inlet to the heart could be viewed as a column of blood that ascends between the two atria from below. So see here, the blood from the inferior vena cava enters into the heart. So this column hits the inter atrial ridge. So this is the atrium. So this moving column of blood hits the um, interatrial ridge. The crista divides and is divided into left and right arm. So left side arm enters into left atrium, right side arm enters into the right atrium. So left arm fills the wind sac found between the foramen ovale valve and the left atrium. The right arm is directed towards the tail and joins tricuspid valve and joins the flow from the SVC and coronary sinus. Next, we are going to see ductus arteriosus. This connects the left branch of pulmonary trunk to arch of aorta beyond the origin of left subclavian artery. It protects the lungs from circulatory overload. The blood arrives via IVC and reaches the left atrium, then it reaches the left ventricle. From there, it enters into the aorta and carotid circulation, then it reaches the vein. The blood arrives via the SVC, reaches right atrium, right ventricle, then enters into the pulmonary artery. Via ductus arteriosus, it goes to aorta to the lower portion of the body. Actually, the ductus arteriosus has 40% or less of the cardiac output directed through the ductus arteriosus. Lung receives only 13% of the cardiac output at mid-gestation, but increases to 20 to 25% after 30 weeks. So, ductus arteriosus circularly has a circularly arranged smooth muscle, which is localized in the intimal cushion. Active muscle contraction pulls the cushion, and this functionally closes the ductus arteriosus. Things which stimulates the closure of the ductus arteriosus are oxygen, which will inhibit the potassium channel. Then this acts on mitochondrium and nervous system. Hence, this produces active contraction of the smooth muscle and closes the ductus arteriosus. In terms of preterms, they have very deficient potassium channel. Hence, ductus arteriosus is open, the baby born preterm. So, the influence of circulating substance like prostaglandin E2, which is crucial in maintaining patency. Sensitivity to prostaglandin antagonist is highest in third trimester and is enhanced by glucocorticoids and fetal stress. Yeah, if we give prostaglandin antagonist along with the steroid, it will produce closure. The increased reactivity of the ductus arteriosus make it vulnerable to prostaglandin synthase inhibitors such as indomethacin. Here, nitric oxide has a laxing effect on it. Then, the structure we are going to see is umbilical arteries. About 64% of blood in the descending aorta goes to umbilical artery. There is right and the left, and the direct branch of fetal internal iliac arteries. Remaining 35% of the blood supplies the lower half of the body under the So main around 65% of blood enters into umbilical artery, 35% enters into the lower limb. So this is the flow diagram depicting all the process which is involved in the fetal occlusion. The blood enters into the umbilical venous system. It around 50 to 60% reaches the umbilical venous blood, which enters into the ductus venosus, bypasses the liver, carrying more oxygenated high velocity blood, which joins with the left hepatic vein and suprahepatic inferior vena cava. This enters into the right atrium. Along with the superior vena cava, the high velocity hits against the ischiation valve and crosses the foramen ovale, enters into the left atrium. Here, the remaining 40% 50% the blood from the umbilical venous blood remain profuse in the left lower lobe of the liver. The, it joins with the portal circulation, mm, main and the right portal vein. These are these are the high resistant hepatic microcirculation, which divides into right and the left. The right enters into um, IVC and enters into the right atrium. These are the low velocity which enters into the tricuspid valve and reaches the right ventricle. Higher oxygenated blood from the umbilical vein to bypass the liver, the right side of the heart. Same thing is explained here. So the umbilical venous system enters into the IVC and IVs main IVC content in the portal venous system enters into the IVC based on the slow flow on the higher flow things get separated. Um, Low velocity enters into the right ventricle, high velocity enters into the right ventricle. So this is a echo sonogram shows a patent foramen ovale. This shows this shows how the blood can enter into the atrium via IBC. This is the tricuspid valve. Blood comes here and the slower thing enters into the right atrium. Faster velocity hit against the foramen well, and it will enter into the left atrium. So these are the partial pressures in each part. So first thing we are going to see is umbilical vein. Saturation will be 80% and PO2 is 13 millimeters of mercury. Okay, in umbilical artery, it is saturation is 55% and PO2 is 22 millimeters of mercury. The blood in the inferior vena cava, saturation is 25% and PO2 is 13 millimeters of mercury. In descending aorta, saturation is 55%, PO2 is 22 millimeters of mercury. In lungs, saturation is 40%. In foramen ovale, saturation is 67%. In superior vena cava, saturation is 25% and PO2 is 13 millimeters of mercury. In case of ascending aorta, the saturation is 65% and PO2 is 25 millimeters of mercury. So, the ductus arteriosus is the continuum of main pulmonary artery and inserts into the aorta at a point immediately distal to the origin of left subclavian artery. Okay, high pulmonary vascular resistance along with the volume load borne by the right ventricle, it will produce significant RVH. So this high pulmonary vascular resistance forces almost all of the ventricular output to enter into the ductus arteriosus, which enters into the systemic circulation via the aorta, and this produces oxygen saturation around 55%, which reaches the gut, kidney, and the lower extremities. And it also supplies the internal iliac artery, and from there it reaches the umbilical artery. From there it reaches the placenta. So this is how placenta has 55% of saturation and 22 millimeters of mercury of PO2. And the whole, in summary, placenta, it is called as a fetal lung, which has 55% of fetal cardiac output. From there, the blood, it is carried by umbilical vein. Saturation is 80%. Through ductus venosus, it enters into IVC directly. The saturation, which which is 26%, and mixed, mixed venous blood from the portal vein system, which carries 26%, joins together from IVC blood, which has SpO2 of 67%, along with the SVC blood. Uh, SpO2 of 26% enters into the right atrium. Then the IVC blood preferential shunted to left atrium via foramen oval. SVC blood preferentially enters into the right atrium via pulmonary artery. From left atrium, it reaches left ventricle, then ascending aorta, then right brachiocephalic artery, left carotid artery, left subclavian artery, and upper body. So saturation of the upper body is 67%, but the blood from pulmonary artery reaches high resistance circuit due to collapsed lung. This blood will be shunted into descending aorta. Okay, so then from there it is the shunted to via ductus arteriosus, descending aorta beyond origin of three umbilical arteries. Then it reaches the lower limb and abdomen relatively unsaturated. So the saturation will be 60% in the lower limbs, and from there it reaches the umbilical artery and it enters into the placenta. Low systemic vascular resistance, secondary to low resistant placenta. It have baby have high PVR, pulmonary vascular resistance, because fluid filled lung and a hypoxic environment which produces vasoconstriction. Minimal pulmonary blood flow because of high pulmonary vascular resistance, low atrial pressure and high pulmonary arterial pressure. The most highly oxygenated blood from the umbilical vein perfuses the brain and the heart, bypassing the liver via the ductus venosus and bypassing the right ventricle via the foramen ovale. High PVR forces most right ventricular output across the ductus arteriosus into the descending aorta, allowing deoxygenated blood to return to the placenta. So here comes the fetal cardiac output. The three important fetal shunt create a circulation that is parallel rather than the most efficient postnatal series circulation. Right ventricular output is 1.3, left ventricular output is 1 because right ventricle has a hypertrophy. The, these ventricles act in parallel, pump different amount of blood and organ receives blood from both ventricles. The combined ventricular output around 400 ml per kg per minute. The demands of parallel circulation results in increased myocardial work superimposed on the demand of a fetus having to grow and develop in synaptic milieu. So, how the oxygen is delivered? Transfer of oxygen across the placental plate is inefficient when compared with the transfer of oxygen in the lung. Breathing room air, which produces a maternal pH of 100 millimeters of mercury, and from there it reaches to the umbilical vein. It carries 30 to 35 millimeters of mercury. So this produces low fetal oxygen tension. Hence, if mother is breathing 100% of oxygen, PO2 of maternal blood can increase to 40, 400 to 500 millimeters of mercury. But umbilical vein will have a partial pressure not more than 40 millimeters of mercury. There will be very modest rise in umbilical venous partial pressure of oxygen. So this has a fetal hemoglobin has a different ODC. Large increase There will be a large increase in fetal oxygen saturation based on the fetal ODC curve. So here we can see the difference of the fetal and the adult. Here, fetal circulation, fetal hemoglobin has a left-sided shifted curve, and they have more affinity, adequate capacity to carry oxygen, and cardiac output that is sufficient to metabolic needs. This both produces the oxygen delivery. Fetal hemoglobin has unique property that allows fetus to transport oxygen despite the low PO2. The partial pressure of oxygen at which hemoglobin is 50% saturated is called P50. The ODC curve of fetal hemoglobin is shifted to the left in comparison with the adult hemoglobin. P50 of fetal hemoglobin is 19 millimeters of mercury. P50 of adult hemoglobin is 26 millimeters of mercury. Because a low level of 2,3-DPG and decreased affinity of uh, fetal hemoglobin for 2,3-DPG causes a left shift of the fetal hemoglobin ODC curve. In vitro, fetal hemoglobin has a sigmoid oxygen dissociation curve similar to adult hemoglobin ODC. The result is that for any PO2, the oxygen saturation is higher for fetal hemoglobin than the adult hemoglobin. So here we are going to see what is a CaO2. A CaO2 divided by 100 into the hemoglobin into 1.3 ml of the oxygen saturation into hemoglobin plus PaO2 into 0.003 ml of oxygen per mercury, millimeters of mercury. PO2 into 0.003 ml is a soluble oxygen. It is very negligible, hence oxygen content of the blood CaO2. SaO2 is the arterial saturation of the hemoglobin. Hp is the hemoglobin concentration. In adult, SaO2 of 100% and hemoglobin of 11 grams per deciliter, CaO2 will be 14.7 ml O2 per deciliter of blood. In a fetus, hemoglobin of 17 grams per deciliter and oxygen saturation of 65%, CaO2 will be 14.8 ml O2 per deciliter of blood. Fetal hemoglobin's affinity is greater for uptake at the placenta At tissue level, acidosis happens. Here comes the Bohr effect, which because of the fetal pH. The normal value is around 7.25 to 7.35, which is lower. Hence, there is a release of oxygen from the hemoglobin, and there occurs the rightward shift of the oxygen hemoglobin curve. So, the main entity which helps in the delivery of oxygen from the placenta to the fetus is double Bohr effect and double Helton effect. Both the Bohr and Helton effect enhances the exchange of oxygen and carbon dioxide across the placenta. The Bohr effect describes the shift of hemoglobin dissociation curve to the right by hydrogen ions, which reduces the affinity of hemoglobin for oxygen. So, mainly the Bohr effect describes a rightward shift of the ODC because of the hydrogen ion. Haldane effect describes the increased ability of deoxygenated blood to carry more carbon dioxide. Carbon dioxide from fetal side diffuses into maternal blood, causing an increase in maternal intervillous hydrogen ions, which reduces the affinity of maternal hemoglobin for oxygen, mm, which increases oxygen transfer to the fetus. At the same time, a relative decrease in carbon dioxide on fetal side cause the fetal blood to become slightly more alkaline, increasing the fetal hemoglobin uptake of oxygen. So this is how the Haldane effect and the Bohr effect acts. Since Bohr effect occurs on the both side of the oxygen delivery and uptake, it has been called as double Bohr effect. Likewise, double Haldane effect describes the maternal and fetal change in carbon dioxide and the oxygen uptake. Fetal hemoglobin becomes oxygenated and releases the carbon dioxide, which has increasing binding to the maternal hemoglobin that has just deoxygenated. Double Bohr effect occurs functionally by the slight opening and closing of hemoglobin chain, allowing a blocking entry of oxygen to the iron hemo binding site. Carbon dioxide binding to the sentinel histidine on the hemoglobin chain can block access of oxygen to the heme binding site. So this diagram entirely depicts what is double Bohr effect, what is double Haldane effect. So this is the spiral artery from the uterine vein, and this is the umbilical vein artery from the uh, fetus. So this is the fetal side. This is the maternal side. Here, what is it shifted uh, right here? ODC is shifted left. This is by the double Bohr effect. Here, because of the double Haldane effect, carbon dioxide affinity is altered. Accordingly, the oxygen affinity is also altered by changing the concentration of CO2 by affinity for phe ion heme oxygen affinity in the central histidine. So next we are going to see about the pulmonary vascular resistance. There is a high pulmonary vascular resistance which restricts pulmonary blood flow to 10%, only 10% of the cardiac output. So, what produces this high vascular resistance in the pulmonary bed? Thick muscular layer, hypoxic pulmonary vasoconstriction, decreased nitric oxide synthase, increased endothelium 1, mechanically a fluid-filled alveoli also produces a high pulmonary vascular resistance. There is an initial rapid fall of O2, then followed by a slow fall because thinning of a medial layer which occurs at 6 to 8 weeks at around 2 years of age. So, what are the change you can expect in the blood volume? In a fetus, there will be an increase in 10 to 20% of body weight. Blood volume in the fetus is around 10 to 12% of the body water, but in adults it is around 7 to 8%. The estimated volume of blood in a fetus is around 80 ml per kg, which is greater than that of adults. Arterial and venous blood pressure. Mean arterial pressure is 15 millimeters of mercury at gestational week of 19 to 21. Systolic pressure increases from 15 to 20 millimeters of mercury at 16 weeks to 30 to 40 millimeters of mercury at 28 weeks. There is no obvious difference between the left and right ventricles. This increase is also seen for diastolic pressure, which is less than 5 millimeters of mercury at 16 to 18 weeks, and it is around 5 to 15 millimeters of mercury increase at 19 to 26 weeks. Umbilical venous pressure increases from 4.5 millimeters of mercury at 18 weeks to 6 millimeters of mercury at term. The fetal heart. The fetal and neonatal myocardial cells are very smaller in diameter, contain relatively more non-contractile mass, primarily mitochondria, nuclei, and surface membrane. Force generation, extent, and velocity of the shortening are low, stiffening, and water content of ventricular myocardiums are high. The fetal heart is surrounded by fluid filled rather than the air-filled lung. Hence, the fetal and neonatal heart has limited ability to increase the cardiac output in the presence of volume, load, or a lesion that increases the resistance to emptying. Cardiac output is more dependent on heart rate. Bradycardia is poorly tolerated by the fetus. Cardiac performance. Myocardium grows by the cell division until birth, and the growth beyond the birth is due to the cell enlargement. The density of myofibril increases particularly in early pregnancy, and the contractility contributes to improve during the second half of the pregnancy. Fetal heart has a limited capacity to increase the stroke volume by increasing the diastolic filling pressure. So here, what they are trying to say is capacity to increase the stroke volume by increasing the diastolic filling pressure. Increased heart rate may be the best single most prominent means of increasing the cardiac output in the fetus. Cardiac output and distribution. The right ventricle output is slightly larger than that of the left ventricle, and the pulmonary flow in the human fetus is around 13 to 25% at 28 to 32 weeks, when the pulmonary blood flow reaches a maximum. This table depicts the cardiac output and distribution in a human fetus during the second half of the pregnancy, according to Rasanen et al. So, combined cardiac output at 20 weeks is to 210 ml, 30 weeks it increases to 960, 38 increases to 1900 ml per minute. So the major contribution is from the right ventricle, which is 53 at 20 weeks, 57 at 30 weeks, and 60 at 38 weeks. And the left ventricle contributes around 47 ml in 20 weeks, 43 around ml per minute at 30 weeks, 40 per ml per minute at 38 weeks. And for a man where the blood is around 34 ml per minute, and at 20 weeks and 30 weeks, that 18 ml per week, and at 28 weeks it is 19 ml per minute. A blood through the lungs is 13 ml at 20 weeks, 25 ml at 30 weeks, and 21 at 38 weeks. And the blood through the ductus arteriosus is 40 ml at 20 weeks, 32 at 30 weeks, and 39 at 38 weeks. The cardiac output and distribution. The lowest saturation is found in the abdominal IVC, and highest saturation is found in the umbilical vein. A thin fetal lung are developed by contain only around 90 ml of a placenta plasma ultrafiltrate. During expulsion of fetus at delivery, this fluid is normally squeezed from the lung by the force of pelvic muscle and the vagina acting on the baby. Any remaining fluid is reabsorbed by pulmonary, capillaries, and lymphatic. Small neonates and the neonate delivered via cesarean section do not benefit from vaginal squeeze, thus typically have a great difficulty in maintaining respiration. They can have a transient tachypnoea of the newborn. Respiratory efforts are normally initiated within 30 seconds after birth and become sustained within 90 seconds. What are the changes postnatally you can expect in this circulation? Change in central circulation at birth are primarily caused by a rapid or large decrease in pulmonary vascular resistance and the disruption of umbilical placental circulation. So, what are the changes you can expect? Sudden cutoff of the placental blood flow, fetal asphyxia, infant gasps for lung expansion, and the lung expands and it produces a decrease in pulmonary vascular resistance, so increase blood flow to the lungs and fall in the pulmonary arterial pressure. Functional closure. This produces a functional closure of the foramen ovale and closure of the ductus arteriosus. Because of sudden cutoff of a placental flow, there is a sudden increase in peripheral vascular resistance and produces a increase in aortic pressure, and this exceeds the pulmonary arterial pressure. So this depicts the pulmonary arterial pressure, pulmonary blood flow, and pulmonary vascular resistance. So once initially it is low, once the birth happens, lung expands, pulmonary arterial pressure falls because and the pulmonary vasculature resistance falls. So arterial pressure falls because of the fall in the resistance, and there occurs an increased blood flow immediately after birth and reaches the normal after that. So what is a transitional circulation? Here there is a transition, it is called the fetal circulation. Here there is a transition to an adult circulatory system. Once lung inflates, increased oxygen tension, which reduces the pulmonary vascular resistance dramatically, increased blood flow, increased blood to the left atrium, which produces the left atrial pressure of fall less than the right atrial pressure. which produces the closing of the flap of tissue, the foramen ovale. So, in case of early cord clamping, this reduces the or removes the or cut off the placenta, which has very low resistant flow, produces rise the SVR, systemic vascular resistance. With the increase in systemic blood pressure and fall in pulmonary vascular resistance flow, through the ductus arteriosus becomes initial bidirectional and then very quickly evolves into left to right shunt. Within the first hours of life, the ductus arteriosus begin to close under the influence of increased oxygen tension, mm, placental prostaglandin loss, and more alkalotic environment of the newborn. Permanent closure of ductus arteriosus takes weeks to occur. After birth, the cardiac output, the right ventricular work decreases because of the volume load is reduced and the pulmonary vascular resistance falls. In a series circulation, cardiac output is the equal volume of blood ejected by each ventricle. Newborn cardiac output is same as that in the vitro, but convention is calculated as 200 ml per kg per minute, which is the output of each ventricle. Left ventricle that must cope with the increased demands. Left ventricle output increases 2 to 3 fold. This is accompanied by increase in the left ventricular preload, stroke volume, and heart rate. Volume growth increase and rise in SVR represent a significant increase from fetal side. The high beta stimulation associated with the labor and delivery, heart rate increases and is near maximum. Newborn must maintain a high cardiac output because its metabolic rate VO2 is around 66 to 7 ml of O2 per kg per minute, which is double that of an adult. The remainder of the increase in VO2 is devoted to the growth and the oxygen requirement of the brain, which is proportionally much longer or larger in newborn. The neonate can increase stroke volume up to a point according to the Frank-Starling relationship if the afterload is kept you. Once a child takes the first breath, pulmonary circulation begins and the right and left heart becomes completely independent of each other. All bypass channels having served their purpose obliterates, foramen oval is closed and becomes a fossa ovalis in the right atrium. Closure of the ductus venosus at birth is entirely passive, secondary to alteration in relative term of blood to the right and the left atrium. The ductus arteriosus constricts in a few minutes after birth. Functional closure occurs by 10 to 15 hours. Anatomical closure completes by 2 weeks. By propatency, ligamentum arteriosum by 3 weeks. So the causes are arterial O2 and the bradykinin. Postnatal closure of the ductus arteriosus is affected in two phases. Immediately after birth, contraction and cellular migration of the medial smooth muscle in the wall of ductus arteriosus. Intimal cushions or mounts functional close within 12 hours after birth in full-term human infant. Second stage completes by 2 to 3 weeks in human infant, produced by infant holding of endothelium and disruption and fragmentation of the internal lamina, hemorrhage and necrosis in the subintimal region. Patency closure of ductus arteriosus represent a balance between the constricting effect of the oxygen, vasoconstrictive substance, and relaxing effect of several prostaglandins. Ligamentum venosum. During ductus venosus becomes a fibrous band called ligamentum venosum, which is seen in continuum with ligamentum teres. Other changes and clinical aspect. Umbilical artery become an umbilical ligament attached to internal iliac and to superior vesical arteries. The left umbilical vein remains patent for considerable time and can be used for exchange transfusions. In the fetal pulmonary circulation, pulmonary arterial pressure, mean pulmonary artery pressure increases progressively up to 50 millimeters of mercury and exceeds mean arterial aortic blood pressure. Fetal pulmonary circulation. Here, total pulmonary vascular resistance early in gestation is extremely high, owing to small number of arteries present. It decreases progressively last half of gestation with growth of new artery and an overall increase in cross section. As I said earlier, with initiation of pulmonary ventilation, pulmonary vascular resistance. See here, pulmonary vascular resistance falls and arterial pressure falls. Blood increases by 24 hours of age. Adult level is reached after 2 to 6 weeks. This is due to vascular remodeling, muscular involution, rheological changes. And mid-gestation pulmonary vascular resistance is estimated to be tenfold higher than it is 24 hours after an uncomplicated birth. During the last trimester, pulmonary vascular resistance decreases slightly to levels even to 8-fold greater than its 24 hours after delivery. Responding to sudden rise in oxygen tension, the endothelium secretes a potent vasodilator, nitric oxide, and prostacyclin. Luminal diameter increases as endothelium and smooth muscle become thinner. The increase in blood flow further recruits small human vessel, leading to an overall increase in cross-sectional area of pulmonary vascular bed. Smooth muscle relaxation occurs in larger pulmonary vessels. This first rapid phase of pulmonary vasoconstriction followed by a period of remodeling that lasts for months. During this time, there is a maturation of vascular smooth muscles with continuing modest decline in PVR. PVR approximates adult by 2 months of age and the remodeling process usually complete by 6 months of age. So, how the pulmonary vascular resistance is regulated? The pulmonary vascular resistance is regulated by the state of oxygenation and the vasoactive substance like nitric oxide, direct potassium channel, physical expansion, change in surface alveolar surface tension. Control of perinatal pulmonary circulation, balance between factors producing active pulmonary vasoconstriction and pulmonary vasodilatation. Persistent fetal circulation, also called persistent pulmonary hypertension of newborn. It is most common in full-term infants. Causes are meconium aspiration, respiratory distress syndrome, pneumonia caused by group B beta streptococci, and episode of asphyxia. Progressive increase in right ventricular afterload, which produces right ventricular dysfunction, results in right to left shunt through the patent foramen ovale or PDA, and it produces a tachypnoea and acidosis. And on examination, there will be a parasternal heave and loud S2 and systolic murmur. On chest X-ray, there will be pulmonary oligemia and no parenchymal disease. Echo and Doppler evaluation will be there to rule out TAPVC. Okay, three forms are described: hypertrophic type, hypoplastic, and reactive type. Oxygen treatment will be oxygenation, sodium bicarbonate, artificial ventilation, inhaled nitric oxide, IV prostaglandins, treatment of severe disease by ECMO. What are the duct dependent circulation? To maintain systemic circulation, coarctation of aorta, critical AS, hypoplastic left heart syndrome. To maintain pulmonary circulation, pulmonary atresia, pulmonary stenosis, tricuspid atresia, and TOF, wherein systemic and pulmonary circulation separate. TGA, transposition of great arteries. Response of fetal circulation to stress. A hypoxic insult activates a hemoreflex mediated by the carotid bodies, vagal effect, reduce the heart rate, and sympathetic vasoconstriction. Endocrine responses such as adrenaline and noradrenaline, maintaining vasoconstriction, increase the heart rate, and reducing the blood volume with renin release, and increase the angiotensin to concentration. Circulatory redistributional pattern that maintains placental circulation and gives priority to adrenal gland, myocardium, and brain initially. This is how the fetal circulation is redistributed. Main blood enters into adrenal, next heart, next brain. Sustained hypoxia forces an adaptational shift to legs oxygen demand, reduced DNA synthesis and growth, gradual return towards normal concentration of blood gases, and endocrine status. In case of premature newborns, pulmonary vascular smooth muscles not developed, rapid fall in pulmonary vascular resistance, early onset of left to right shunt, and congestive cardiac failure. Ductus arteriosus open has no development constriction response. High level of prostaglandin E2 and are deficient in potassium channel, which will produce a rapid fall in pulmonary vascular resistance, promotes the left to right shunt. Oxygen dilates the pulmonary and constricts the ductus arteriosus. Acidosis increases the hypoxic pulmonary vasoconstriction. Pulmonary artery is dilated by oxygen, vagus, beta stimulation, and bradykinin, constricted by hypoxia, acidosis, sympathetic stimulation, alpha adrenaline stimulation. Ductus arteriosus is dilated by hypoxia and acidosis, constricted by oxygen. Autonomic innervation of heart, parasympathetic nervous system predominates early in the life. Okay, while sympathetic nervous system is still developing. This imbalance is clinically relevant and can be used as a marked bradycardia or even asystole during the laryngoscopy. Orogastric tube placement or tracheal suctioning in the neonatal infant. Many anesthesia provides all pre-treat with anticholinergic, atropine, or glycopyrrolate prior to airway instrumentation. Temperature. With a large surface to mass ratio, newborn is at a significant disadvantage of maintaining temperature. It is its compensation is to use its high metabolic rate to generate heat for temperature hemostasis. After umbilical cord clamping, flow through ductus venosus ceases, causing it to involute with no possibility of any flow. The ductus venosus does not play a role in problems during state of transitional circulation. Persistence of fetal circulation most commonly occurs in instance of severe prematurity with RDS. Hypoxia is a potent stimulus maintaining a patent ductus arteriosus. Direction of flow depends solely on the relative resistance between the systemic circulation and the pulmonary circulation. Flow through the PDA is usually left to right, adding an additional volume burden to lung that is already coping with RDS. Significant RDS can be accompanied by elevation in PVR that are high enough to cause bidirectional or even right to left shunt at PDM. The evaluated PDA also raises right heart pressure, causing same phenomenon to occur at the foramen level. A patent foramen level provides an opportunity for intracardiac right to left chanting. Any other type of lung disease that is severe enough can also cause persistence of the fetal circulation. NSAIDs via their antiprostaglandin action can be used to induce closure of patent ductus arteriosus. Indomethacin is the preferred agent. Difference between the fetal circulation and comparison of newborn circulation prior to ductus arteriosus closure. This is after the ductus arteriosus closure. Thank you.